My primary role is as a surgical oncology PA. However, I do help with general surgery cases. In our clinic, we do a lot of surgical resections of multiple cancers, so skin cancer, breast cancer, stomach cancer, other GI cancers as well. We also have a hepatobiliary clinic where we evaluate patients with liver cancer, pancreatic cancer, bile duct cancer, gallbladder cancer, and others as well. So today my presentation is on the ins and outs of colorectal cancer. Learning objectives. I want you guys to be able to familiarize yourselves with the trend in increasing diagnosis of colorectal cancers in younger patients or younger individuals, to recognize the importance of colonoscopies for colorectal cancer screenings, and then also to identify surgical techniques in the resection of colorectal cancers. So you can see my table of contents here. So now let's get started. We are going to start with the poll everywhere question. So how many of you know someone who was diagnosed with colorectal cancer? So according to the American Cancer Society, colorectal cancer is the third most commonly diagnosed cancer and the third most common cause of cancer-related death in both men and women. According to the National Cancer Institute, in 2025, there's estimated to be about 154,270 new diagnoses of colorectal cancer, which is about 7.6% of all new cancer cases. 950 new cases of rectal cancer. It's been stated that the lifetime risk of developing colorectal cancer is about 1 in 24 for men and 1 in 26 for women. However, each person's risk depends on their risk factors for colorectal cancer. Now, colorectal cancer is swiftly shifting to more advanced disease in younger individuals, according to the American Cancer Society. In fact, recent ACS reports suggest that 1 in 5 people diagnosed with colorectal cancer are now under the age of 55. In 20% of colorectal cancers in 2019 were in people 54 years or younger, which is up from 11% in 1995. So this steep increase in young and middle-aged adults alongside with decreasing trends in older adults has rapidly shifted the patient population. Also, colorectal cancer is rapidly shifting to a diagnosis in the left colon or rectum. Rectal cancer is largely driving the early onset trend, with the proportion increasing from 15 to 28%. So over the most recent decade, incidence in individuals younger than 50 years increased by 2% per year for rectal cancer versus 0.5% and 1.6% per year for tumors in the proximal and distal colon, respectively. So now we're going to talk about some colorectal cancer risk factors. It's important to recognize these risk factors. So when we think about genetics, as an individual's family history of colorectal cancer is an important consideration. History has shown that a positive family history of certain cancers is associated with an increase in risk of that cancer. Another consideration are inherited genetic syndromes such as Lynch syndrome, FAP, cystic fibrosis, PJS, MAP, etc. Now, more than 1/2 of all cases and deaths attributed to colorectal cancer are attributable to modifiable risk factors. One modifiable risk factor is excess body weight and physical inactivity. Obesity and a sedentary lifestyle are linked to higher colorectal cancer rates. A 2022 article suggests that obese individuals have about 1.27 risk of developing colorectal cancer when compared with non-obese individuals. Another modifiable risk factor is diet. So of course, diet high in processed and red meat, but low in fiber, fruits, and vegetables are known to increase the risk of colorectal cancer. which equates to a high-fat, low-fiber diet. Lastly, alcohol consumption and tobacco use are also modifiable risk factors. Studies show that long-term tobacco use and heavy alcohol use are associated with a higher likelihood of developing CRC. Now, for some non-modifiable risk factors, age. Even though we're seeing a shift to diagnosis of younger individuals, increasing age is still strongly associated with the risk of colorectal cancer. Gender incidence rates of colorectal cancer are slightly higher in males than in females, and a personal history of precancerous polyps or colorectal cancer, ulcerative colitis, IBD, history of radiation to the abdomen or pelvis, all increases in individuals' risk for colorectal cancer. In fact, there's a strongly positive association between the incidence of ulcerative colitis and risk of colorectal cancer. As you guys are probably aware, polyps are non-cancerous growths in the lining of the colon or rectum. Benign polyps include tubular adenomas, tubulovilous adenomas, and villous adenomas. Precancerous polyps include serrated, hyperplastic, and sessile polyps as depicted by the picture on the screen. Now, it's important that precancerous polyps are completely removed, and this is usually done via polypectomy during a colonoscopy. Of course, malignant polyps typically contain cancer cells, and a biopsy of those polyps typically reveals adenocarcinoma. Now, I don't want to spend a lot of time on stool sampling, but I do want to point out a few things. So a FIT test is just an immunochemical test that detects blood in the stool. Now, pros of this is that tests can be performed at home. However, they also have a high false positive rate. You may miss some polyps or tumors that do not bleed or bleed very little. And then they also result like an incorrect answer, so to speak, in warmer climates or if there are any postal delays with mailing in the card. So for the DIAC test, it checks for occult blood in the stool. Again, this test can be completed at home, but some cons of this is that it requires multiple bowel movements. It requires an avoidance of certain foods leading up to taking that test. It does not provide a visual exam of the colon or the rectum, and again, you may miss polyps or tumors that bleed very little. And then for the FIT DNA test, which is a test that's probably very widely advertised on commercials, the Cologuard test. It detects microscopic amounts of blood in the stool and looks for certain DNA changes that are found in cancerous tumors or precancer polyps. It has a high detection rate for early colon cancer stage or early colon cancers. However, it has a high false negative rate. And again, it does not provide like a visual visualization of the colon or rectum. So shifting to colonoscopy. Again, colonoscopies provide a full visualization of the colon and rectum. Flex SIGs only the rectum or lower part of the colon. And so flex SIGs are used mostly when symptoms of the tumor is localized to the lower colon. However, current evidence suggests that colonoscopy screenings results in about a 32% reduction in colon cancer mortality. But sadly, we still have a significant number of patients who just absolutely refuse colonoscopies. So that brings me to my next slide. So some common reasons why patients refuse colonoscopies include lack of time, lack of interest, lack of need, fear and mistrust are all examples or reasons that patients cite. I actually had someone tell me that he was not having any kind of anything in his butt. So sadly, he was like in his 70s and never had a colonoscopy. So, a lot of patients sadly complete FIT testing as a reason for not completing a colonoscopy. They all say, oh, well, we did the test that you can do at home, but again, that does not allow you to visualize the colon or the rectum. So consequences of refusing a colonoscopy equates to a missed detection of cancer or a tumor. Now, I want to briefly mention a procedure that's gaining some traction in the UK. It's known as a virtual colonoscopy, aka CTC or CT colonography. It's a well-tolerated, minimally invasive procedure. Based on extensive studies, it's demonstrated performance comparable to that of an optical colonoscopy or regular colonoscopy. It's very underutilized in the United States. And so by a show of hands, does anyone at their institution know about using CTCs? That's good.
Do you use Cologuard?
I'm sorry.
Do you use Cologuard?
So yes, something that we use at our institution. It's not our favorite thing, but so some of the surgical treatment options that we offer robotic assisted procedures. And again, a pro of this kind of surgery is that it's minimally invasive, fewer conversions to open surgery, shorter hospital stay, shorter recovery. It's less blood loss, less tissue damage, less post-op pain, better cosmesis. And a lot of patients reach recovery milestones like passing first gas or stool pretty quickly. Surgeons are still equally successful in getting clear surgical margins and retrieving sufficient lymph nodes for sampling during this procedure. However, one of the cons is that it is a longer operation and overall higher cost than the other two procedures. Another procedure that we use a lot with at my institution is hand-assisted laparoscopic surgery. And so a con of this is it's minimally invasive, shorter operative times than robotic surgery, but a little bit longer than open procedures. Similar recovery time to robotic surgery, less blood loss and tissue damage, better cosmesis. Again, surgeons are successful in getting clear margins and retrieving sufficient lymph nodes for sampling when compared to open procedure as well. But some cons of a hand-assisted surgery is that it's more blood loss than robotic surgery, higher rates of converting to open, and it's a longer recovery time to reach milestones like passing first gas or stool bowel movements. Now, for open surgery, you try to do this out of the least or as probably less frequently, I guess is what I'm trying to say. But some of the pros of open surgery is it's a better approach to managing complications. It offers direct visualization, shorter operative time. However, it also results in like a greater blood loss, higher risk of complications, greater tissue damage, greater scarring, longer recovery. So it's important to note that robotic and laparoscopic procedures offer similar oncological outcomes and complication rates. And we typically determine which operative approach we're going to take by considering the patient's BMI, surgeon preference, and then of course patient preference as well. So now we're going to dive into a case. So we evaluated a male patient in his mid-40s with a past medical history significant for hypertension and diabetes. He presented to his primary care doctor with complaints of hematochezia. PCP ordered a CT of the abdomen and pelvis, which revealed an abnormal appearance of the rectum. Shortly after the CT scan, he underwent a colonoscopy that showed a 2-centimeter rectal mass at the anal verge involving the lower third of his rectum. Biopsy of the mass showed a moderately differentiated adenocarcinoma. And of note, this tumor was actually palpable on a digital rectal exam too. He also completed a PET CT, which showed mild heterogeneous activity at the rectal wall, suggestive of malignancy and possible malignant perirectal lymph nodes at the right side of his rectum. He opted for treatment closer to home, where he was initiated on chemotherapy and radiation. So a repeat staging CT scan showed grossly stable mass in the rectum. That was about 15 millimeters, a 10 millimeter right lower lobe nodule, a new low attenuating lesion in the right hepatic lobe measuring about 12 millimeters, which were findings compatible with metastatic disease, and then an 18 by 15 millimeter metastatic perirectal nodule. So sadly, this patient reported he missed several appointments with his medical and radiation oncologist. He eventually lost his job at work, and so then he lost his medical insurance too. So by the time we evaluated him at my institution, and it was actually the medical oncology team, he reported completing an unknown number of actual chemotherapy and radiation cycles. He was a poor historian, and we had incomplete medical records, so no one could really verify like the exact number that he completed. He delayed workup at my institution due to various personal challenges, but finally he underwent a biopsy of the liver lesion, which showed metastatic adenocarcinoma consistent with the colorectal primary. About a month after starting treatment at my institution, he presented to the emergency room with right lower leg pain. He was found to have a PE, and so he was started on a Pixpan. His chemotherapy regimen was changed to regional 5FU, and so we discussed his case at our tumor board meeting, which ultimately recommended resection of the liver lesions. So now another poll everywhere question, actually we can just do by a show of hands. Or if you guys can just blurt out the answer. What are some of the patient challenges you've encountered in your practice?
Insurance.
Those are good ones.
Accessibility.
Patient understanding.
All great answers. Very, very important. Thank you. So here are some of the challenges to medical care that patients can face. So my patient, or the patient that I'm talking about for this case, he reported numerous personal challenges. And so I thought it was appropriate to review some of these. So on this slide, reported patient challenges as it relates to accessing medical care and the consequences of those challenges. One of the challenges that he reported was that he travels a long distance to our institution. He said he lives about 2 hours away, kind of rural Houston. Additionally, he reported a lack of personal transportation, thus he relied on public transportation, specifically a bus, for all of his travel to our facility. He also said that he had no idea infusion appointments take so long, so when he was told that he would have to be there for 4 hours at least for an infusion appointment, he just refused to get it done that day because he said his bus had to leave by a certain time. He also, of course, lost his job and lost medical insurance as well. So, changing gears to colorectal treatment, I want to briefly speak about the different approaches to colorectal cancer. Our team tightly adheres to the NCCN guidelines, but NCCN recommends that chemotherapy is administered concurrently with radiation prior to surgery. First-line treatment for intensive chemotherapy is FOLFOX, which is 5FU, leucovorin, oxaliplatin, or FOLFIRI, which is 5FU, leucovorin, or irinotecan. And so these are the options that are typically used by our medical oncology team. Addition of chemotherapy to neoadjuvant radiation has been found to improve localized disease control, resulting in tumor downstaging, which is something that we really want when we take someone to the operating room. And then also perirectal node sterilization. Now, a newer treatment approach that is currently being evaluated is known as the watch and wait approach. This is also known as the organ preserving approach. And so for this approach, patients are treated with chemoradiation, then they are monitored for tumor recurrence. It's thought that tumors that recur after non-surgical approaches are frequently amenable to surgical resection if they come back. So this approach requires careful selection of patients, and several European trials have documented the watch and wait approach, and our medical oncology team is actually a part of a trial too that's investigating this as well. However, the patient was not a candidate for evaluation. So now I also want to talk briefly about regional versus distant metastasis. As you guys are aware, tumor metastasis is the dissemination of cancer cells from the primary tumor to lymph nodes or other organs. As such, it's important to distinguish between regional and distant metastasis. So regional metastasis is when the tumor invades nearby structures and organs, whereas distant metastasis, tumor invades distant structures and organs like the lungs or bone. So liver is the most common site of metastatic spread, owing to the fact that most of the intestinal mesenteric drainage enters the hepatic portal venous system. Nearly half of patients undergoing surgical resection for their primary colorectal cancer will eventually develop liver metastasis. And if not treated, liver metastasis exhibits an unfavorable prognosis with median overall survival of 5 to 20 months about. Now, there are multiple treatment modalities available for colorectal hepatic metastasis, including surgical resection, also tumor ablation. However, only surgery provides a curative intent for these patients. So it's estimated that about 10% of all patients with colorectal liver metastasis are candidates for potentially curative hepatic resection. 5-year survival for these patients is about 30 to 45%. Resectable colorectal cancer liver metastasis are tumors that can be completely resected, leaving sufficient number of the liver remnant behind. So contraindications to liver surgery would be radiographic evidence of hepatic artery or major bile duct or main portal vein involvement or celiac or para-aortic lymph node enlargement or presence of extrahepatic disease as well. So now a traditional approach to synchronous metastasis has been the resection of the primary tumor first, followed by chemotherapy, and then resection of the metastatic tumor. However, this approach is criticized a lot because if a metastatic lesion was initially resectable, by the time the patient is treated, then that convalescence could result in like an unresectable tumor. So now the thought is to resect the metastatic lesion first, and then chemotherapy, radiation, and then resection of the primary tumor. So this patient underwent a liver segmentectomy with us, and I just want to highlight a few things from that procedure. So we typically start by performing a diagnostic laparoscopy or a survey of the abdomen. We use the laparoscopic ultrasound to survey the liver, specifically looking for the bifurcation of the portal vein. The segment A mass was the only visualized lesion in the right lobe, but he also had another lesion that was identified in segment 4B, and that appeared to be about less than a centimeter, and so we went ahead and resected that as well. But both liver lesions were resected with at least 2 centimeter margins. Now, I just want to highlight a few post-op complications. Now, post-hepatectomy liver failure is something that we are absolutely worried about. It's the most serious complication after liver resection, and it can be very life-threatening. However, it is fairly uncommon due to the significant improvements that surgeons have made in the surgical technique and perioperative care of patients. Hemorrhage is another serious complication after liver resection. Again, it's also fairly uncommon now as well as bowel leakage, acute renal failure, ascites, surgical site infections, wound dehiscence, blood loss. This patient actually had an uncomplicated post-op course, which was really good because we were concerned. So next, we took him to the operating room to resect his primary tumor because, again, for curative intent, his colorectal cancer needed to be resected as well. And so, again, I just want to highlight a few things. His tumor was noted to be adherent to the anterior surface of the sacrum. Sharp dissection was used to carefully mobilize the tumor away from the sacrum. The anus and sphincter complex were dissected circumferentially and removed unblocked with the rectum and distal colon. His precervical fascia was ablated using electrocautery to remove any microscopic residual tumors that may be adherent, and an end colostomy was created in his left lower quadrant. Now, these are possible post-op complications from colorectal surgery. Surgical site infections are the most common early post-op complication. Other complications included wound dehiscence, anastomotic leakage, paralytic ileus, abdominal sepsis, small bowel obstructions, and some systemic complications that could possibly occur include pneumonia, DVT, acute myocardial infarction, and urinary tract infections. Sadly, this patient actually had a surgical site infection, so we treated him with antibiotics. So what's next? So when he had a repeat CT scan, it also showed that there was a nodule in his lungs as well. So the lungs are actually the second most common site of metastasis from colorectal cancer. It's estimated that 10% of patients with colorectal cancer will develop lung metastasis. The resection of the isolated pulmonary mets increases survival rates to 40% across 5 years, which is good. And again, pulmonary resection should be considered for patients with controlled or controllable primary tumors. Actually, I wanted to go back and say that we presented his case again to our general multidisciplinary tumor board. And so everyone recommended to pursue a biopsy of the lung nodule. And then if that was positive for cancer, to offer him radiation. So in summation, there is an alarming increase in incidence of colorectal cancer in younger patients. I cannot stress enough the need for more education regarding the need for screening. It is vital that providers partner with their patients to formulate a treatment plan while stressing the importance of adhering to that treatment regimen and schedule. So even with all of his personal struggles, we really needed to take time and explain, hey, your tumor is progressing because you're not receiving care, essentially. The liver is the most frequent site of colorectal cancer metastasis, and surgery is the only curative attempt. And current guidelines do not support surgery of primary asymptomatic tumors and metastatic colorectal cancer if the disease cannot be completely resected. So here are a few of my references. And